You're listening to episode 226 of Mitolife Radio. I'm your host, Matt Blackburn, and today I'm interviewing Dr. Christy Sutton on iron and genetics, and specifically iron overload. I've covered this topic extensively over the years, but what I really appreciate about Dr. Christy is that she acknowledges that iron deficiency also exists. But she does shine light on what she calls the silent epidemic of hemochromatosis, which is a gene mutation that causes you to absorb excess iron. So she talks about the two main variants, the two types of hemochromatosis. She shares some possibilities of why somebody could be iron deficient, including parasites, gut dysfunction, and why high iron doesn't necessarily equal low copper. If you've listened to any of my previous shows on iron overload, I think you'll really enjoy this one. So here she is, Dr. Christy Sutton. All right, Dr. Christy Sutton, welcome to the show.
Thank you.
Yeah, this is going to be a fun chat about iron, specifically as it relates to genetics and the iron topic. A lot of people know me by that. They've actually found my podcast because of my talks on iron the last couple of years, but it was this really unbalanced perspective of everybody has iron overload. Nobody has iron deficiency, which I found out is not true. And then especially when you get into genetics, I know one of the world's foremost iron, maybe the number one iron expert, Robert Crichton, he said iron deficiency is, or iron overload can only come from hereditary hemochromatosis genes. And it's very rare if someone gets it outside of those genes. So yeah, I willy-nilly donated blood a few times. First time I felt great, like Superman. Second time I felt destroyed. Took me months to recover. So maybe you want to delve into that too, of the whole blood donation nuance and stuff.
Yeah, sure.
But yeah, how did you, before we kind of dive in, how did you get interested in this subject?
Well, during the process, I married a man who was undiagnosed hereditary hemochromatosis is really how it all started. And then I realized that he had high iron before I realized he had the hemochromatosis gene. And he would occasionally bring home his blood work from his primary care doctor, and I would see slightly elevated liver enzymes, slightly elevated ferritin, and I would tell my husband, you need to go have some blood removed. Occasionally he would listen to me. Occasionally, growingly with the marriage, it became less and less. And then in writing my first genetic testing book, Genetic Testing, Defining Your Path to a Personalized Health Plan, I discovered the hemochromatosis gene, and I discovered my husband had that gene. And then I realized, oh, okay, this is what we're dealing with. And he wasn't addressing it. His medical doctors were not addressing it. So we went to a specialist, the gastroenterologist, and went on a misdiagnosis rabbit hole that we could have easily avoided if that gastroenterologist had just kind of heeded my warning. And because I gave the gastroenterologist like the genes and the labs, and I said, I think it's high iron messing up his liver, which he listened to me, and then he kind of dismissed that to go down his own path, which is a long story short, was a misdiagnosis that I had to order more tests to pull him out of. And then eventually he sent us to a hematologist that got it right straight off the bat. But the gastroenterologist thought he had polycythemia vera because he had not just high ferritin, high liver enzymes, but he also had high red blood cells, high hemoglobin, which is common with people that have high iron, especially with people that have that hemochromatosis gene. And so we go to the hematologist, we get the proper diagnosis. Most things improve with my husband as far as the liver enzymes slowly come down. My husband has some other little issues genetically with glutathione. And so that's something we have to constantly kind of work on, which is a compounded problem if you have high iron, because high iron and low glutathione is kind of like the recipe for disaster. So anyways, most things got better with my husband, except for his DHEA was still high. So then we went to the endocrinologist, and we found out he had a pituitary tumor that was causing him to have Cushing's disease, high cortisol, which in doing, actually, I always wondered if they were connected. And then as I really did like a deep dive into iron, I realized that hemochromatosis damages the pituitary gland, specifically the part of the pituitary gland that my husband's tumor is on. So my unprovable suspicion is that they're connected, and we're still in the midst of that. My husband's going to have a second surgery to have that worked on and have that tumor removed, because that's really the surgical cure. But so after going through that with my husband, this was years ago, I obviously started looking at a lot of people's genes, and I've always looked at their labs and their iron levels, but I really started getting much more sophisticated about really screening for and diagnosing these type of things and referring out. And what I learned was that there is a silent epidemic of hemochromatosis, and you do not need a hemochromatosis gene to develop high iron. And if you only have one hemochromatosis gene, you're still at a high risk for high iron. And it is quite common to have hemochromatosis. It's just not commonly diagnosed. And so I would refer out those patients, and they would often get they would get almost ignored and given bad advice, like, oh, you can't have hemochromatosis with that genotype, or you're fine. And so I just, in the process of that, got so frustrated with it, and experience after experience, that I felt the need to, publish and write my book, which is soon to be published, The Iron Curse. So that's long story short.
Wow. That's incredible. What would you say, and I think this is one of the listener questions, which one do you see more than the other?
Iron
high or low? High or low, yeah.
Okay, I'm going to preface this with most of my patients are females. So females tend to have issues with low iron more often because of menstruation and childbirth. I have a fair amount of male patients, and even some of them struggle with low iron, especially if they're new patients. But those people tend to have more of like a GI bleed, that type of thing. There's a reason they're low in iron. And once that underlying problem is addressed, then they tend to be better. That iron issue tends to get better. And, sometimes they can even go high in iron after that. Now, it's really, you see it all. I do think that I probably see more iron deficient anemia. And some of those people are iron deficient anemia maybe because they are low in copper, but most of them, it's not that. Most of them, they're females that have heavy menstrual cycles. They've gone through pregnancy once or twice or 3 or 4 times. These are things that are just drains on iron. And, if you are trying to lower your iron, then we know that removing blood is the fastest way to do it. So if you believe that to be true, that removing blood is the fastest way to lower iron, which it is, because what is in blood, hemoglobin, and red blood cells have lots of hemoglobin in them. What is on hemoglobin? Iron. So if we know that to be true, then of course females that are constantly losing blood are going to be at a high risk for low iron, because there's just a tremendous amount of blood that is lost for certain females that have heavy, long cycles. And then pregnancy is just, even people that have that hemochromatosis gene, females with that hemochromatosis gene, they tend to even need high doses of iron while they're pregnant as well, because iron is just a total sponge. Pregnancy is a total sponge on iron. And in my book, I have a whole section on just anemias and a chapter on iron deficient anemia. And in that chapter, I talk about how if you go into pregnancy with low iron, your child that you are pregnant with is more likely to have a low IQ, like a significantly lower IQ, and various neurological problems that are avoidable if you just, were healthy going into pregnancy. And part of being healthy is iron. We need iron. It's one of the most important things in the world, which is why the hemochromatosis gene exists.
That's awesome. Yes, so many questions. I guess we can just start going down each one. Ferritin is one that I changed my mind on after listening to Robert Crichton say it's an accurate marker. But it's my understanding ferritin, is like the gold standard for measuring iron deficiency. But a lot of people make the argument that it's an acute phase reactant, so it's a marker of, inflammation, so it can be falsely, elevated or whatever. I was instructed by a practitioner to donate blood with the ferritin of sub 70. Is that a good idea in your opinion?
So there's a couple different things to address in what you just said. One is ferritin is an acute phase reactant, but it is also a marker for iron. Obviously, it's not perfect, but sometimes we have to kind of just do the best we can with the information we have. And it is an inexpensive, easy lab to run. So we must run it and take it seriously. Now, you can see somebody that you can actually have high ferritin and be anemic. That's called iron deficient anemia. And that is one of the many different types of anemia that I discuss in my book. And so what iron deficient anemia is where you have all of this inflammation, and then that inflammation causes you to make more hepcidin, because when your body has an infection or is inflamed, the liver makes this thing called hepcidin. And it's basically a way that the immune system will take the iron out of the blood, because the immune system knows that pathogens, almost all of them, with the exception of Borrelia Lyme, need iron to survive. And so the immune system knows that. And so it uses iron as a way to take the iron fertilizer away from the pathogens. And the tool that it uses to do that is called hepcidin. So if you are inflamed, if you have an infection, the liver makes lots of hepcidin. And then that hepcidin will decrease iron absorption. But what it really does is it stops the iron from getting into the blood, and then the iron is forced to either get stuck in the intestinal lining where it will slough away. You'll poop the iron-rich enterocytes away in your stool, or it'll go into your liver as ferritin, or it will go into your macrophages, and those are like white blood cells. So, and then there's lots of consequences that can come from that. But inflammation, or even that'll happen with high iron. But where that doesn't happen, so the hepcidin will get high if you're inflamed, and that causes that high ferritin, but it also causes low iron. So we have to look at ferritin. If somebody's not inflamed, then ferritin's a pretty good lab marker. And the ranges of ferritin are really key. So, and it can change quickly. Like if you get labs done when you're sick, your ferritin's going to be higher significantly than if you get labs done when you're not sick. And, you can see that. And that's where you just have to closely look at the CBC and, symptoms and what's going on with that person and say, okay, is this an inflammatory marker? And sometimes it's hard to know, especially if it's like a chronic inflammation. And that's when you just really work on decreasing the inflammation period. And so there's different ways to do that. Now, there was another question that you asked where I just went on a tangent, and I'm sorry, but there was another question that you asked that had to do with donating blood at ferritin of 75. That's where it's really important to look at the whole picture. And so if you're just looking at ferritin, it's like, well, that's a snapshot and I need that information. But what I also need is what is your hemoglobin and what are your red blood cells and, what's going on with your white blood cells and what's going on with your TIBC and your UIBC and your iron saturation and serum iron. And, you have to look at all of those at a bare minimum, the full iron panel and the CBC. And for some, and you also, in my opinion, you really need those hemochromatosis genes. Because if you see somebody that has a hemochromatosis gene, then you know that they have a genetic predisposition to absorb more iron, and they need to be managed more aggressively.
Mm. It's
So,
awesome. Yeah,
yeah.
I brought up my test just to reference, and yeah, my iron saturation said it was low. Well, it was 13%, and then my hemoglobin was actually below 11, so that was also low in the
Yeah, you
thing.
wouldn't, that, in my opinion, that wouldn't be a great situation for donating blood.
Yeah. Oh, sorry. Actually, that was one of my clients I was working on. That was the wrong one, but still a good example. So
Yeah.
that was actually a woman I was helping up in Idaho. But yeah, still, I think I had my hemoglobin wasn't high, and my iron saturation was actually pretty low still.
Yeah, that's not a great situation.
Right.
So, but for removing blood. Okay,
Mm-hmm.
so if you can have iron loading anemia. Iron loading anemia is where you have high iron combined with anemia, which is where you have maybe low red blood cells, maybe hemoglobin, but you're effectively anemic with high iron. And you cannot remove blood in that case, because then you're not only going to be dealing with you will decrease the iron, but you will also create a pathological situation where somebody's going to be exhausted and feel terrible because you just took a bunch of red blood cells and hemoglobin out of them. And so this is like what you see with a thalassemia type patient. So not to say you have to have thalassemia to have this issue. There's lots of different things that can cause this iron loading anemia. But with thalassemia, they tend to have abnormally shaped red blood cells. And then because those red blood cells are abnormally shaped, when they're going through the capillaries and they get damaged, and then they don't make it through the whole life cycle that they should. And so then they get taken out of circulation quickly. And what ultimately happens is you get low in red blood cells. And then that can create actually a high iron situation, because as those red blood cells open up, they lyse and they let all this iron out. And then that iron, you get like extra iron in the blood. But simultaneously, these people are often treated for low blood cells by giving them transfusions, blood transfusions, and then they get high in iron because they're getting all that extra iron, which they don't need. Wow. They really need the red blood cells. Does that make sense? That's kind of confusing.
Yeah, it makes sense.
So, but with those people, you can't use blood removal. Like you have to, in my book, The Iron Curse, like I have the Iron Curse protocols. And if you can't remove blood, well, then there's diet, there's supplements, there's all these other things that you need to do and can do to support lower levels of iron without damaging your red blood cells.
That's great. One question I was thinking of as I was preparing for this interview is, I know, certain organs have an affinity for iron, like the liver, different parts of the body. Is that why, could you have iron overload locally in certain parts of the body where it's not systemic?
Yeah. So, usually the liver's the first place to get hit. And the reason for that is because the liver is where the body has kind of designated the liver as the iron storage organ. And that's not an accident. Like the body is really smart. It does everything by design. And part of the reason for that is because the liver is also where you have lots of glutathione, and you have these really important antioxidants that can help the body to neutralize a lot of the free radicals that iron creates. Because when you get high iron, then basically you're dealing with a high oxidative stress situation. And what that means is basically you're dealing with the body's rusting from the inside out when you put a lot of iron into the equation, too much iron into the equation. So you can think of it as cut an apple, and on one half of the apple, put lemon juice on one side. And then on the other half of the apple, don't put anything, just both of them sit there. And of course, the apple with the lemon juice has all that vitamin C that's going to be an antioxidant to protect it from the oxidative stress of the air. So, that apple's not going to get damaged like the one that doesn't have the lemon juice. So with iron, it's like you have the damaged brown rusting apple. You're rusting from the inside. So the liver's the first place to get hit. That's where we naturally store iron first. But as iron levels increase and as iron dysregulation increases, then it will start to spill out. Because the body kind of has a infinite ability to store iron because we don't naturally excrete a lot of it unless we're bleeding. And so basically, once that liver is tapped, then it will start spilling out too. It likes to go to the heart and damage the heart, the pancreas, creating diabetes type issues, the gonads, destroying the gonads, creating infertility, low testosterone in men, hormonal imbalances in females. It likes to go to the brain and destroy the brain, creating Alzheimer's, even age-related macular degeneration, which is a neurodegenerative disease, Parkinson's, any neurological problem, bipolar, schizophrenia, depression. It likes to go to the pituitary gland, especially in the brain, the anterior pituitary gland, not the posterior pituitary gland. The anterior pituitary gland is where you're going to be making like your thyroid stimulating hormone, so it'll affect your thyroid. It'll make your ACTH, which will affect your cortisol. It'll make your growth hormone. So people that have high iron at a young age, which is commonly undiagnosed, they often will have like a shorter stature. So it'll, and then it'll affect your LH and your FSH, which will affect your gonads' ability to make estrogen, progesterone, testosterone, those type of things. So eventually, as iron spills out and, gets higher and higher, it'll go everywhere. That's where it'll start depositing in your skin, creating like a bronze. They actually used to call hemochromatosis bronze diabetes because they would have diabetes because the iron destroyed their pancreas, but then they would also have this bronzing color from the iron, the high iron creating that situation. But yeah, it'll, you name a problem and I'll tell you how iron does it. It can just do about anything.
Wow. That's also necessary for life too, right?
It is. Yeah. And that it's a double-edged sword. That's actually like the first chapter of my book, The Double-Edged Sword of Iron. We need it desperately. And as I'm going to circle back around to what I said before, because I think it's important, but the reason for the hemochromatosis gene is the fact that iron is necessary for survival. And so the hemochromatosis gene, which is this gene where you have an increased iron absorption, it originated in a Celtic Viking ancestor thousands of years ago during a time where it was a low iron environment. These people, they were warriors, they would sail long distances. And historically, history has had all of these iron deficient gauntlets, that famines. If you think about all of the things that deplete iron, famines, injuries where you lose blood, not just in pregnancy, you're going to lose a lot of blood during pregnancy, menstruation. If you want to make it to have a child, which evolution really controls the genes that get passed into the future through pregnancy and childbearing, you better have good iron levels to get those babies, to and through conception and delivery. Just to be able to have a period. If you're low iron, you might even not be able to have a period. Being a young child growing, they need a lot of iron. So there's all of these things that iron is really necessary for. And so this gene, iron is important because this gene is extremely common in the population. Around 30% of the population has it, even higher in Northern European Caucasian populations, but there's a lot in America because think of all the people that have come here from Northern European populations. And so it's the highest in Ireland. And the reason for that is not just because it originated in a Celtic Viking ancestor that was traveling around that area, but because even as recently as the Irish potato famine, there was this huge evolutionary bottleneck, basically. And the people who had that hemochromatosis gene were more likely to survive the Irish potato famine because that was a low iron situation. And then what happened was the people who survived had children, and maybe they were heterozygous and they married somebody and had kids with somebody who was heterozygous, and then those kids were homozygous. And so there was this explosion of people that were diagnosed with high iron. And still to this day, that's the highest percentage population as far as the genes go. And even in Ireland, there's a low percentage of diagnosis. And there's this myth, and it's the worst. I have a whole chapter about it. It's called the carrier myth. There's this myth that if you only have one of those genes, you're just a carrier. And that is wrong.
Wow. That's awesome. I didn't know that about the Ireland and the potato famine. That's fascinating.
Yeah, it really is.
What are your thoughts on parasites? Because I know some people have their whole practice centered around this, and I've done countless, cleanses in the past, colon cleanses and stuff, and anti-parasite cleanses. I know like tapeworms, hookworms, intestinal parasites, a lot of those can cause iron deficiency. How prevalent do you think it is? Because I know here in the US, it's like people that aren't in the natural health world, they assume that's more of an issue when you travel to South America or a different continent or something like that, a different country.
Yeah, it's interesting. I used to work with this lady who was from South Korea, and she just thought it was so amazing that people in America have decided they're going to start eating sushi, but they're not going to do the annual parasite cleanse that the people that, have eaten sushi for so long, for generations, have kind of learned that's a part of their just health routine. And, if you talk to people from Southern America or Central America, like our receptionist is from Honduras, and she's like, well, every year we do a parasite cleanse. And we just go to the store and we buy our parasite medicine, and we just do it every year. So it's really interesting that, we're eating sushi, even if we were not eating sushi, like parasites are out there. Yeah. But yeah, there's this myth that you don't get parasites in first world countries. And that's obviously not true. But I think the real issue from what I've seen is that I don't think doctors are trained to really properly diagnose and treat parasites. And I'll tell you a short story to kind of elaborate on that and kind of explain a little bit more why I believe that. So I recently had this young, I think he's in first grade or boy, autistic. He was very constipated, and he did a stool test on him, Genova Diagnostics PCR stool test. He had a parasite, so they take it to the pediatrician, the results. Pediatrician's like, oh, that's fine, that's normal, we don't need to do anything about that. So, that's painting a whole nother story. It's not even about like, are they out there? It's like, are they getting treated? And I think you can come to your own conclusions, but I think that in general, doctors are not really good about diagnosing and treating them. Even if you go to the doctor and say, hey, I think I have a parasite, I would be surprised to see what like the average doctor, what they would actually do, what would they actually test for? Because the stool tests that I've seen them do are not as good as the ones that like I have seen through the other companies. And so if you're not looking for something, it's hard to find it.
Right.
That's kind of, I think, the same thing goes for the iron issue. If you're not looking for high iron, because like a lot of doctors are not doing a full iron panel, are looking for the hemochromatosis genes, like, yeah, it's easy to make up all these myths if you're not actually collecting the data. So that's part of the problem. But if we're going to circle back to iron, which is really, what your question was about, yes, parasites do cause iron deficient anemia, and there's a lot of different reasons for that. But they certainly do. Yes.
A lot of people might have this burning question. So how do you find out if you have the hemochromatosis gene? I think before we started recording, you mentioned 23andMe is usually most
Yeah.
accessible for people and most common.
Yeah. So 23andMe is the company that I have the most experience with at this point in time. I don't think any company is perfect, but that is, I feel like, kind of the industry standard at this point in time, for better or worse. A lot of people have already done that test, which is valuable for them to come to you and they already have the information. They have been in business for a while, whereas some other companies that I've tried to use kind of fell off the map. So I circled back around to them. And so, yes, they do check for the hemochromatosis genes. That's a part of their health reports. And if you don't pay for those health reports, then you can still find out if you have those hemochromatosis genes by ordering the genetic detoxification report. And that, I believe, is using a direct-to-consumer company such as 23andMe, which is not the only option out there. There's others out there. You just want to make sure they're checking for the hemochromatosis genes, because a lot of them don't, which is a big oversight, I believe. But that is, I think, the easiest way to find out if you have these genes, because, honestly, it is harder than you would expect to get these genes tested through like a general practitioner. My husband's hematologist checked them after I had already given him the report, which I appreciated, like trust but verify. But I've seen it go the other way, with other patients. My colleague's daughter, we diagnosed her at age 5 with hereditary hemochromatosis. Took her to the pediatrician. Pediatrician confirmed hereditary hemochromatosis. It was wrecking her health. She reverted back to diapers. She could hardly walk. It was destroying her brain. And so it's a long story. I talk about it in the book and in the Iron Curse workshop. But when she went to the hematologist, she gave them her daughter's genes, and then they circled back around like months later in this email chain that I actually have in the book because it's so disgusting. But in the email chain, they basically said, like, can you give us, I don't know if you ever gave us the genes. Can you give us the genes? Like this was like months later after they had already seen her in the office. And it's like, she was sent to you for hereditary hemochromatosis and you didn't even check her genes. Wow. And you lost what Dr. Penchak gave you, because this is my colleague, Dr. Penchak, like she's a doctor. And you just have to see this email in my book. It's like, they don't know anything about hemochromatosis. They don't know anything about hemochromatosis. They didn't check for the genes. They decided not to treat her. They told her she was fine. The only reason her iron levels came down was because Dr. Penchak started her daughter, who had 5-year-old with juvenile hemochromatosis, put her daughter on supplements to lower iron. Hematologist said, get her off of those supplements. It's not helping. So she takes them off the supplements, goes back, iron comes up, and they're just like, we're not dealing with this. She's fine. And they would send her back to the regular pediatrician. Wow. So it's just ridiculous. And then they said, we don't know why she's tired because she's not anemic. And it's like, okay, you don't know that hemochromatosis causes fatigue. And they're like, her liver enzymes are normal. Normally it's the liver that's a problem. It's like, okay, her brain is also getting damaged here. Her liver enzymes used to be high and now they're lower because like she lowered iron somewhat. What else was it in that email that was so bad? There was something else. It was, anyways, it's in the book and I talk about it in the Iron Curse workshop. But that's just an example of how doctors are not checking for these genes. My neighbor, she's a wonderful PA, just wonderful. She was like, how do you check for those genes? I tried to figure out how to do it through Quest and I can't. I'm like, okay, you need to get your patients to do 23andMe.
Mm-hmm. So Christy, I pulled up I just searched HFE and there's the little report. And I've actually done this before. I recognize the page. So it says, Matt, you have one of the 2 genetic variants we tested. So one variant detected in the HFE gene, and it's the H63D variant, which I actually happen to have pulled up in your book here, page 376. And you make it really easy in your book, just laying it out. Mm-hmm. And then I click the scientific details to see the genotype is CG, which in your book you said if you have the genotype CG, then you're unlikely to be affected. But if it's GG, then you're at increased risk for developing a mild form of hemochromatosis.
Yeah, I wrote that book a long time ago, and I've learned a lot since then. And I need to go back and update that book. And the iron curse is going to basically take the place for anything I've written in the past regarding to iron, because it's a whole, I mean, I have like a whole huge chapter just on those genes. Wow. Now, when I wrote that book, I was going based on what medical established theory was. And that's wrong. Okay. And that goes back to the whole carrier myth idea. Now, I have since really learned that even if you have one of those genes, then you are at a higher risk for having hereditary hemochromatosis. Okay. So with each gene that you have, the risk will increase. So there's 2 hemochromatosis genes. So the one that you have is less likely to cause high iron than the other one, which is HFE C282Y, but you are still at a high risk. That my husband has the same genotype as you, and he developed high iron. It was messing up his liver, really messed him up pretty bad. And so, theoretically, you could inherit 4 of those bad genes, because there's the HF C282Y, and then there's the HF H63D. So you could inherit either of those, and then you get one from your mom, one from your dad. And so you could have 4. So 2 is worse than 1. You're going to be more likely to have high iron with 2 versus 1. 3 is worse than 2. 4 is just, I've never seen anybody with 4. They're probably in Ireland. But personally, I haven't seen it. So that what I wrote there is not as accurate as what I'm teaching in the iron curse. And what I'm teaching in the iron curse is based on what I've seen, which is that most of the people that I've seen that have hemochromatosis, that actually develop hereditary hemochromatosis, that have that gene and develop high iron, most of them only have one gene. Like they've only inherited one risk allele. And the reason for that is because they are the highest percentage of the population. And so they might be at a lower risk, but there's so many of them that they still, at least in my practice and in some of the research that I cite, they are still the majority of people that actually develop high iron. Having said that, if you inherit more of those genes, 2, 3, 4, or if you inherit, especially 2 of those high-risk C282Ys, you're at a much higher risk. That's just a smaller percentage of the population.
Interesting. I like that you're continually evolving. It takes a really intelligent person to admit that. And I've done it multiple times, and it's a beautiful thing to evolve. And as you learn more and dive deeper into research, I think it's really great. So
I appreciate that. Sometimes it takes swallowing your pride.
This book, your old one, it's still incredible. The genetic testing book, I still love it. I think there's a lot of gold in here. So
thank you.
Let's see. I had a few questions kind of from stuff we talked about earlier. So the systemic inflammation thing, do you think highly sensitive CRP is a good marker? I know that's the main one. The last time I had that tested, I was low. So can I assume that I am in a low inflammatory state?
I think it's worth measuring, but I know for a fact that you can have inflammation and still have a normal or low CRP. And there's a lot of reasons for that. There are actually some genes that are in the genetic detoxification report that basically you create that report using 23andMe data. And there are some genes that show that you're more likely just to have high CRP than others. So just because you have a normal CRP doesn't mean that you're not going to be inflamed. And I can tell you, personally, the most stark experience with that for me was a couple of years ago. I had this horrible Crohn's flare because I go through this story in my gut and immune workshop with laborgenomics, but I had this horrible Crohn's flare. Like, I've had Crohn's since I was 16. I'm 41 now, and I had never had anything like it. And I have theories or two as to why it happened. But basically, long story short, at one point in time, I was very closely monitoring my C-reactive protein, which at one point in time came up to 100, which was quite high, like hospitalization high. I never was hospitalized, but I was watching that with the calprotectin, which is a stool inflammatory specific to your stool marker. And the calprotectin went really, really high with the CRP. And then like the CRP dropped and the calprotectin stayed high. And so while Crohn's is largely inflammatory, it's inflammatory bowel disease and it's more specific to the digestive system, that's still like a huge amount of inflammation in the body. And I was shocked. My gastroenterologist was shocked too, to see that CRP like in a very low normal range while I was still high calprotectin and, not completely out of the flare.
Wow. And was that a fecal test where you found the calprotectin?
Yeah.
Okay.
Yeah. So calprotectin's fecal, and that's a wonderful test for, if you want to know about inflammatory bowel disease. It's underutilized, but it's wonderful.
Wow. That's awesome. Yeah. I was like an hour and a half away from labs. Now that I'm 30 minutes away from civilization, I plan to do a whole bunch of tests. And now that one reached that, you just made that number one on my list.
Yeah. Well, gastroenterologists can and do order it. What I found is that you have to actually request it. Unfortunately, it's not something they're like, hey, we need to do this. They like to recommend colonoscopies and EGDs because as somebody that's like, I actually used to be an endoscopy tech and like helped with a lot of endoscopies, colonoscopies, and EGDs. And I can tell you that like that's where they make their money, with the colonoscopies and the EGDs. And they are, valuable tools for diagnosing and treating, especially early cancers. I'm not saying don't get them. I'm just saying that those tend to be the money makers for the gastroenterologist. So that's kind of the emphasis, I feel like. And they are valuable tools. I feel like some of the other cheaper, less invasive, less, financially beneficial tests sometimes get overlooked. And calprotectin, I think, is one of them. Now, you can get a calprotectin like with a really good quality stool test, like a Genova Diagnostics or something like that. They're GI effects. But of course, you're going to have to pay out of pocket for that. But, that's just where we are in healthcare right now.
Yeah, that was another question I was going to ask. Like, how would you find out if it's a gut issue causing low iron? Like I have the GI stool map that I still need to send in. Do you think that's a pretty good one?
That's certainly a valuable tool worth ordering if somebody has low iron, and it doesn't make sense. Like if it's a female that just has, heavy periods, it's like, I think I know what's going on here. But you can still be a female with heavy periods that has a parasite or a GI bleed, or, 2 or 3 things can happen at once and you need to address all of them. For a male, especially a male with a hemochromatosis gene, if you see them with a low iron and like they're not a total vegan, vegetarian, then you better start digging. And the digestive system is, the first place I would start digging, because GI bleeds are a common cause for low iron, especially in men and women. And then, those good quality stool tests will also look for parasites. So that's a great place to look. And you can look for inflammation. And if you have a lot of inflammation in your digestive system, then your iron is not going to be absorbed as well, period.
Yeah, it's a good point. Are you a fan of the ion panel? I know you mentioned Genova earlier, like the
what's in the ion panel? I'd have to say, I don't know.
It's like the 40 amino acids, like it's I think it's blood and urine. Um,
I don't feel like I have any experience. I don't know enough about it to comment. It could be wonderful. I just don't know enough about it to comment.
yeah, some of the guests I've had on are all about. Every practitioner has their different, go-to tests that they use. I
Totally.
like to just look at all of them. It's kind of fun.
Yeah. I mean, at some point in time, usually what's the limiting factor is money
Mm,
for, the patients and what they can and are willing to pay for. And so, I guess that's just not one that I have felt the need to go to, you
mhm.
know,
How
maybe
often?
someday.
Yeah. How often does your husband donate blood? Now that
Okay, so he is under the management of the hematologist,
mm,
and he used to go a couple times a year. Now he goes only once a year, which I don't think
mm,
is enough.
mm,
But so he has a lot of doctor's appointments at this point in his life because of the tumor that he has on his pituitary gland. And every time that they order labs on him, which is quite often, I will always request that they order the iron related labs, and they usually do. They won't do that without me asking, but they will usually if, we ask them. And
mm.
so I'm at this point in time keeping a very close eye on them, more so than anybody else. And then if it goes high, then I just send him to the hematologist and, they take blood out of him. And that did actually happen recently. A couple months ago, he's been managed really, really well for a while now. And then they dropped it down to this once a year rather than twice a year. And we picked up that his iron saturation went up slightly. His ferritin wasn't still too bad, but the iron saturation went up slightly. So, and his liver enzymes were still okay.
Mm.
Um, but we caught it early. And so he went to the hematologist, and the hematologist took out, I think, half a pint of blood. I don't think they were ready to take out a whole pint of blood. But my husband's a really not good patient. Like, he doesn't listen to me the way that he should. But part of that is because he has this disease, Cushing's, where he has high cortisol, and that does a number of things. One is it's really bad for your brain, and then two is ultimately if you do anything to lower cortisol, like if I tell him to do something that lowers cortisol, he doesn't like it because his body's addicted to high cortisol.
Mm,
He wants that energy
mm.
surge, right? And so if you do something to help lower it, he doesn't like it. And he thinks, well, you're hurting me. And it's like, I'm not hurting you. You just have a tumor that's causing you to have high cortisol.
Interesting. Yeah, that sounds like quite the challenge.
Yes. I think God wanted me to be a better diagnostician and clinician when we were introduced.
Yeah. um, well, do you want to jump into some of the questions? Because we have
I'd
quite a
love to.
few, and
I'd love
yeah,
to.
I think it'll be a great jumping off point. So, this is a really good one. How many more milligrams of iron does someone absorb if they have hemochromatosis genes?
Yeah, so that's a really good question. And there's not like one obvious answer to that. And the reason for that is because hemochromatosis, while there are genes that can increase your risk for hemochromatosis, high iron, it's totally an environmental disease. Like, the genes can increase the risk for high iron, but if you're not like ingesting enough iron, you're not going to go high. So the amount of iron that can be absorbed, it depends on how much iron you're eating, what type of iron you're eating. Is it heme or non-heme? Heme iron
Mhm.
is found in animals like beef. Non-heme iron is found in plants. Heme iron is exponentially more absorbable than non-heme iron. This is why vegetarians and vegans, even the ones that like to eat lots of spinach, are low in iron. They're not absorbing it for multiple reasons. So how much iron you're eating, what type of iron, how healthy is your digestive system? Do you have a healthy digestive system?
Mhm.
You're going to absorb more iron. Unhealthy digestive system, you're not going to absorb as much. Um, Are you taking like vitamin C or eating a lot of vitamin C rich foods, which will enhance iron absorption? Are you taking an acid reducer drug, which will decrease iron absorption? There's so many factors, and I go through all the environmental factors in my book and my workshop. But the average person absorbs around 2 to 3 milligrams of iron a day. So we tend to absorb about 10% of what we consume. So if you consume 30 milligrams of iron, then the average person will absorb like 3 milligrams of iron. Okay. People with hemochromatosis, some research has shown, can absorb up to 9, 10, 11 milligrams a day of iron. That is exponentially more. That's like putting away a little bit of money every day in your bank account. And eventually that is just, it's huge. It's like compound interest over time. Whereas losing a little bit of iron every day, like because maybe you have a GI bleed, or you're just not consuming enough, or you're just not absorbing enough, that's like taking a little bit of money out of your bank account every day. And eventually you will have iron deficient anemia. So it's there's so many environmental factors. Now, if you look at total iron, like the average person has around 6 grams of iron in their body stored. Hemochromatosis people can go up to 50, they've been shown to go up to 50 grams of iron. That's way more. That's a lot of iron. So iron likes to be stored as ferritin first, and then as ferritin eventually gets plateaued, like it'll plateau at a certain amount, and then the iron's like, well, ferritin's like, we can't do it anymore. Like the iron's been, like a hoarder. We put it in the closet, we put it underneath the bed, and then it starts overflowing into something called hemosiderin. And hemosiderin, no plateau. Hemosiderin, the sky is the limit. Hemosiderin will go up until you die. And then after you die, the hemosiderin will break down and you will have lower hemosiderin. But as long as you're alive and you're, able to store more iron, hemosiderin will find a way. And hemosiderin will go and it will deposit in your organs, and it will travel all over the body, and it will just destroy you.
How do you test hemosiderin?
That's a really good question. And, there's not a really good direct to consumer or even, direct to doctor option with, LabCorp, Quest, all these, big name labs. There is a test. There is a urine test. It's not really that clinically applicable in my experience from hemochromatosis. Having said that, I really need to do more research on it. But hemosiderin is used more in research. Okay. So like hemosiderin, hepcidin, these are things that we should be measuring in the blood, and we're not. And ultimately, I think it comes down to the fact that it's an expensive, hard to do test, because certain molecules, like they have very short half-lives, maybe they're very small. And that, I think, is my understanding of why hemosiderin and hepcidin are not readily available. But they should be. They are certainly available for research labs, but they just haven't made it to, the big everyday practice yet.
This is kind of a good segue. Someone asked, what are the optimal ranges for ferritin? The reference range is so wide. And I guess we could preface this as someone, has low inflammation, shown by multiple markers. The one that you mentioned before, calprotectin, low calprotectin, low HSCRP, what would be the, good range for ferritin there?
Yeah. So this is really an area that there's a large amount of disagreement. And it's not just like me versus another practitioner. It's like lab to lab, they have totally different reference ranges. Some will let ferritin maybe go up to like 130. Others will let it go like up into the 400s. There is apparently a movement amongst doctors to allow ferritin to go up to 1,000 before it's flagged as a problem. I don't know. This is just what people are telling me that are patients. I'm sorry. If that's the case, that's just like really lowest common denominator healthcare. It's like, do you want to wait until your patient is dead before you like treat them? But basically, I don't like to see ferritin above 100 on adults. In my personal opinion, if ferritin's above 100, you either have high iron or inflamed. I don't particularly think that either of those are good. But again, I never look at just ferritin. I always look at ferritin with the full iron panel and the CBC. And then I also always look at the CRP, and, I try to look at as many different things as possible to see, and I want to look at the genes. So if you have those key pieces of information, then you have a better idea as to why is this high? Is this high because of iron? Is it high because of inflammation? Is it both? And what the next best treatment step is. But personally, in adults, I don't want to see it higher than 100. And if they have those hemochromatosis genes, then, likely lower than 75, because you just need to manage things a lot closer with them because they, have so much more of a high risk for going high and not getting managed properly.
Do you look at zinc and copper? I know a lot of practitioners put a lot of stock into, ceruloplasmin, that kind of form of copper, but
I have started to look more at them. I think that ceruloplasmin is a lab marker worth running. I haven't been overly swayed by just looking at regular copper. Unfortunately, the lab that I use doesn't do a red blood cell copper. So that's something that I think that is worth looking at, and I want to do more research on. The zinc, I occasionally run zinc on people, but typically I'll look more like, do they have like whites on their fingers for low zinc? Whenever I run a zinc, it's never one of those things that's like out of range, high or low. And then you kind of have to make this clinical decision. Like, are you low? Are you high? Are you just right? Is this lab BS? What's going on here? There is a gene that I talk about in my first book, the genetic testing book, that increases your risk for low zinc. So if I see that in combination with like white spots on the fingers, then I will think, okay, maybe we need a little bit more zinc here. But then you have to remember, like, zinc does bind to copper, which can make you low in copper. And as far as copper goes, I think it's hard to go based on labs for just copper. Ceruloplasmin, I think, is a little bit better, but you have to know, and a lot of people don't understand this, there is a condition, Wilson's disease and Medsky's disease, which are genetic diseases that make you so that you become copper toxic. You get copper buildup in your tissues. And if you give those people copper, it's like horrible for them because they cannot excrete it through their ceruloplasmin like normal people. And those people will show up low on labs, low copper, low ceruloplasmin. So just because labs say you're low does not mean you're low. And actually Wilson's disease is a very complicated disease. In my upcoming Iron Curse book, I include, and I'm going to be adding them to the genetic detoxification report, I include the genes for Wilson's disease, the two main genes for Wilson's disease, but there are more. We need more research on that. I'm not at all happy with the information out there yet on that, but I have a feeling that in the next decade, as Wilson's genetic testing becomes more common, we're going to realize there's a lot of people that are carriers for this, that like have one gene, that are having copper related, like high copper, low ceruloplasmin issues. And they're just, and even the research has shown that Wilson's disease carriers can have health problems like tremors, neurological problems, high iron overload, high liver enzymes. So the carriers are affected too. I just don't think we're really good at diagnosing that yet. So I actually prefer people get their copper from their food, but I've started running those tests more. I just think I don't have enough clinical data. And if you go to a hematologist, they're not running any of that. What they're running, what standard medical doctors are running, whether you believe it's good or not, it's worth knowing, they're running the full iron panel, they're running the CBC and the CMP. And they'll want to look at the genes too.
Interesting. Yeah, a lot of people I've heard say that doing the zinc and copper, looking in the plasma or the serum, that's not where it's stored. Zinc and copper are going to be in the tissues. I mean, you think of liver, beef liver, it's like copper in liver. It's not going to be floating around in the blood. But I wonder if the serum or plasma is still a reflection, kind of like ferritin is a reflection of iron in the tissues.
So I have heard some people say that when you're low in copper, the copper will go up on the serum. I don't have enough data to say that's true or not, but I think I think copper and ceruloplasmin are definitely worth looking at. I just put more stock in ceruloplasmin than copper, and I really, in a perfect world, I'd be able to look at, all these labs and everybody. But I live in the real world where I don't take insurance. My patients have to pay out of pocket. And at the end of the day, people have limited resources. And, it's about, let's get you as healthy as possible with the resources you have. So if I had limited resources on everybody, we'd all have thousands of dollars of labs, but that's not realistic. And, people without, a huge bank account deserve to be healthy too. Now, is that good for my research and data collecting? No.
Yeah, I don't know if it's accurate, but I heard like if you want to get every lab test out there, it costs like $20,000 US or something like that. Sounds accurate.
Yeah. I mean, there's so many. Yeah. And you just kind of have to prioritize. But what's interesting about copper is I hear a lot of people say like high iron is just low copper, which is not true. But you actually need copper to absorb iron. So because there's an enzyme called hephaestin that requires copper, and in order to absorb iron from your intestinal lining, you need that enzyme. So, but then what happens is once it's absorbed, the iron requires ceruloplasmin. So ceruloplasmin is the other copper-dependent enzyme. That ceruloplasmin helps to transfer the iron onto the transferrin so that then the iron can transfer around the body on the blood, because the transferrin is like the chaperone for iron, and iron's like very mischievous and wants to go out and like damage things. And transferrin is like, you're not going to just go do whatever you want. Like, you're going to go where we tell you to go. And so the reason that the body has all these enzymes and mechanisms, they're checks and balances for iron, like, because we can't just have iron going in and out of the cell willy-nilly. Like, we have to be able to control it in multiple different steps. So we control it with hephaestin, which requires copper. So if you're low in copper, you're not going to be absorbing iron, but you're also not going to be transporting it throughout the body on the transferrin. And then that can create iron overload in the tissues, which is why, and this is an issue also for some people that have hemochromatosis, is they'll get even more iron built up in their tissues because they don't have enough copper in some cases. And really, when you are low in copper, it can significantly lower ceruloplasmin, which is a problem because ceruloplasmin protects from oxidative stress because it helps to manage iron. That is why ceruloplasmin is considered an antioxidant. It helps its ability to manage iron and stop iron from going willy-nilly causing problems is why ceruloplasmin is an antioxidant. It's not like glutathione peroxidase, which is just an antioxidant enzyme, or superoxide dismutase, which is an antioxidant enzyme. No. Its ability to act as an antioxidant revolves around iron.
Interesting. Wow. It's kind of an interesting question. Is being a heavy sweater a guarantee for iron deficiency? And
No.
I, because I guess some people say you sweat out copper, and I've read, I mean, zinc, iron. I think you sweat out
You
every.
can,
That's not to a
yeah,
crazy degree, right? But you do
yeah, you
lose
can
all
sweat
mineral.
out a little bit. So like the average person will lose around 1 milligram of iron a day through either sweat or just like what's called skin desquamatization, which is where you just kind of like slough off skin. So, or like through your stools, there's, so an average about 1 milligram a day of iron is lost. So there is a way for the body to decrease iron through, your skin and sweat. It's just not efficient. It's not efficient. Like it is not going to make up for increasing your absorption of iron exponentially because you're consuming too much, absorbing too much, have the hemochromatosis gene, etc. If your plan is to sweat out the extra iron, then, it's a bad plan. And if you're low in iron, it's not because you're sweating too much. Sweat, you're really going to lose a lot of, you can't, you will lose minerals, but you're really going to lose a lot of like electrolytes like potassium and sodium and that type of stuff. So yeah, not a good way to decrease iron.
Do you use coffee with your hemochromatosis patients? Because I know that inhibits iron, but there's some nuance there with like the type of iron it inhibits, right? Heme versus non-heme. And
yeah. So coffee and tea, actually green tea is a little bit better than coffee, but coffee, tea, things with tannins, that type of stuff, they can significantly decrease iron absorption. They tend to decrease non-heme iron absorption more than heme iron, but it's certainly a way to manage iron absorption. There's lots of different ways to manage iron absorption, and that I think is a great way to do it. Having said that, me personally, I tend to be more the iron deficient person, which is one reason that I can't jump on the everybody's high on iron bandwagon, because I see so many people with low iron and I've personally dealt with it myself. So you're not going to convince me otherwise. But, personally, you really have to think when you learn about iron and you learn about all the things that can increase iron, you have to simultaneously be able to flip them on their head and say, these can also, these same things that I'm saying, use these to lower iron can cause low iron. Mm-hmm. So like the iron curse protocols that I have that, diet, supplements, all those things that can lower iron, which is therapeutic for people with high iron, that can be pathological for people that struggle with iron deficient anemia.
And do you address that in the book, The Iron Curse, for people that have low iron?
Mm-hmm. Yeah.
Oh, that's great.
Yeah. Yeah. No, I have a whole section on anemias and a whole chapter on low iron. And if you're not interested in that, you can pass over it, but it's fascinating, so you shouldn't. And then, I have a whole chapter on what environmental factors increase your risk for high iron, what environmental factors increase your risk for low iron. And if you turn them on their head, they're often the same things. For example, eating a high iron diet, obviously that will increase your risk for high iron. Eating a low iron diet, that's the most obvious, easy one. But like taking vitamin C, increase your risk for high iron. Not taking vitamin C, increase your risk for low iron. Taking aspirin, getting a GI bleed, increase your risk for low iron. Taking high doses of curcumin. So a lot of people use a lot of these supplements for inflammation, but they also lower iron. So like I ran into that myself because I have Crohn's, I have inflammatory bowel disease. Curcumin is excellent for inflammatory bowel disease. It also is really good at lowering iron. I don't struggle with high iron. I'm a menstruating female with Crohn's disease. That's not my battle to fight at this point in my life. So I have to be careful. It's really frustrating, to be honest with you. I would love to take, 3 grams of curcumin a day, but I have to think so closely about all of it. Like I can't take it at this point in time. And it's frustrating.
Yeah. This is a good one, and kind of on the same point. Any risk with using a cast iron pan to cook with? causing iron overload?
Yeah. So full disclosure, in my house, we have 2 people with hemochromatosis genes, 2 out of 3. My husband, my daughter, not me. I love cooking in cast iron. And I will go down, like, that will be the last thing to go. And so I check my husband and my daughter's iron closely. And, make sure that I'm not unintentionally hurting them. So far, so good, I think. Having said that, there is no doubt that you do get a little bit of extra iron in your food when you cook with cast iron, but it is minimal and it is non-heme iron. Okay, it's not heme iron, it's non-heme iron. Non-heme iron is not very absorbable. Now, but you do get a small amount, okay? And if you have high iron, like really high hemochromatosis, which a lot of these people that by the time they get diagnosed, they have like 1,000, 2,000, 3,000 ferritins, they're on like death's doorstep. And, the smallest amount of iron is not going to do them any favors. Those people need to let go of the cast iron until they get managed. And then if they want to reintroduce it, they can. But if you're managed in a healthy range, then yeah, cooking in a cast iron, and if you can get away with cooking in cast iron, then, you can get away with it. Just like a lot of those people can get away with still eating red meat and shellfish once they're in a managed range. It's just they need to be careful about getting their iron levels checked, taking certain supplements and, eating a certain way to help lower iron simultaneously. Now, when you're cooking with a cast iron, the foods that tend to increase the iron the most are acidic foods, just because they're going to leach out more of that iron. So like if you look at the research, they like to look at like cooking a spaghetti sauce, okay? Because that's like, acidic, and that's like going to be the most exaggerated increase in iron. And so there is a little bit of increase. If you have really high iron, it's probably not the best idea. If you're managed in an okay range, I say go for it.
That's awesome. Thoughts on medical iron infusion?
I hate them. I'll tell you why. I need to drink a soda water. I have a lot to say. Okay. I actually have a whole chapter. Actually, I don't think it's a chapter. I talk a lot about iron infusions in my book. So here's the deal. If you need an iron infusion, then there's something wrong that needs to be fixed. And they're treating the symptom and not fixing the underlying problem. Whatever the reason is, you keep going anemic, which is usually a bleed, heavy menstruation, fibroids, for some women, pregnancy, which drives me bonkers, because in my opinion, pregnant women are not watched closely enough for low iron, and doctors allow them to get low in iron, far too low in iron before they say anything, and then they don't treat it aggressively, and they're just setting them up for needing an iron infusion, because it's like, well, we don't want you to die, so we need to give you an iron infusion. And yes, when those are your 2 options, death or iron infusion is the better option. The better option is let's fix the underlying cause if we can, and give you adequate amount of iron in your diet and supplements so that you don't need an iron infusion. Here's why I hate iron infusions. Remember how I talked about how iron's this mischievous little child that likes to go out and cause problems? And transferrin is the chaperone that's like, don't cause problems. There's no transferrin in iron infusions. You took away all of the checks and balances. Iron is meant to be absorbed through your digestive system. We have all of these enzymes that are designed to make sure that the iron doesn't go and create problems, and to manage its absorption and make sure it gets just on the right transferrin so that it doesn't create problems. When you just put it straight into your veins, that iron doesn't have the transferrin. It's just going out there and it's causing problems like serious oxidative stress problems. And I cite those research articles in my book. There's no doubt it is causing massive amounts of oxidative stress in these people. And it's so irritating to me, because so often these people are already chronically ill or pregnant, and they don't need another oxidative burst in their body, but they're giving them that. And if that's necessary, then at least, please, at least give them the antioxidants to protect them. Give them massive amounts of glutathione IVs and vitamin C IVs. And even they've had research that shows not only those, but vitamin E helps reduce that oxidative stress. But do that while fixing the underlying problem if you can.
Mm-hmm. Yeah, that makes sense. I know a lot of people have reached out to me, mostly women, where they're just, very tired, like can barely get off the couch or get out of the chair. And in those cases, maybe they can implement an advanced strategy like that, utilizing C and E and glutathione with infusion. But it's usually like the go-to, right? Like just run to that first.
It's depending on the doctor. Yeah. I mean, most doctors don't know very much about nutrition. Most doctors don't understand how much iron you have to actually give somebody to get them out of a low iron hole because they're so iron deficient anemic. They're not comfortable diagnosing that much. They are not giving an absorbable form of iron. They're giving ferrous sulfate, which is awful. And, women don't comply often because it makes them constipated. It upsets their stomach because they're taking a low quality form. They're not getting the underlying problem fixed. Maybe it's a GI bleed, a heavy menstrual cycle, whatever. Yes, you can fix iron deficient anemia with iron in your diet to an extent. If you have a if you have like a 16-day period because you have fibroids, that's going to be a hard one to fix. And then those fibroids need to be fixed. You can't keep bleeding like that. That's not a sustainable situation. Iron infusion or not, you've got to fix the underlying problem. But yes, what I see happening, and I experienced this myself when I was pregnant, like I was watching my iron levels very closely throughout pregnancy and started supplementing way before my doctor told me to, because I was already showing signs of low iron and going in a range I wasn't comfortable with. And then by the time I was shocked at how quickly I went even so much lower. I just had no idea I was going to go that low that fast. And then the doctor says, yeah, you're anemic. You need to take, I think he said like 30 milligrams of iron. I'm like, I started taking like 60 milligrams a month ago. And now you want me to take 30 milligrams? Like he didn't even know I was already taking 60 milligrams. It's time to add 30 milligrams. So I think I went up to like 130 milligrams. Actually, that was in addition to my prenatal, which had 30 milligrams. So I was like at 160 milligrams a day of iron for months during my pregnancy. I mean, and that dug me out of that hole. But so many pregnant women or even people that just have low iron because of another reason, they don't realize how much they have to take to dig them out of the hole. And maybe some of that is that some of these people maybe do need a little bit extra copper. But when it comes to like being pregnant or bleeding heavily, it's really iron. Like iron is the limiting factor for so many of those things.
What about iron absorption with celiac disease? I know you mentioned you had Crohn's.
I have celiac too.
Ha. Oh, wow. Because they say that's one of the common causes of iron deficiency anemia.
Oh yeah, because think about it. It's you don't have the ability to absorb nutrients because your intestinal villi are destroyed. I talk about this in the gut and immune workshop. I actually talk about the celiac genes in my book. But basically, if you don't have those intestinal villi, then you're not going to have the surface area to absorb nutrients, and then you're going to become low in everything. It's just iron deficient anemia is often one of the first things that gets diagnosed, although it's still diagnosed very late. But yeah, celiac disease, untreated celiac disease will cause low iron.
Interesting. Wow. Yeah, it seems like there's so many factors, and I think probably if someone could do the best of two worlds, it's like maybe up their iron to get some energy back while they're fixing the underlying causes. Because
yes,
I know for a lot of people, it's just so distracting when they're just deathly tired and fatigued all the time, to where they need some really quick, immediate thing to feel better and then work on all these other things.
Yeah, 100%.
I think that's all of the good the good questions here. Let's see. What does low MCV and MCH with normal hemoglobin and red blood cell mean?
Okay, so MCV is like the size of your red blood cells. And so if you see like a low MCV, then that is often or a low MCV or a low MCH, both of those, that can be like a low iron situation. And you said with normal hemoglobin?
Mm-hmm.
Yeah. So then you would have to say, well, what is normal? Like, is it 12.5? Is it 12.6? You know, is it 15? What is it? Because if it's like 12.5, 12.6, 13, then, well, you need to make sure that you're also getting that iron panel. You don't diagnose iron deficient anemia with just hemoglobin or MCV or MCH. You diagnose it with, you really need that full iron panel with the CBC, which has the MCV, the MCH, the hemoglobin, the hematocrit. And everybody's going to look different. But if you have enough things telling you the same answer, then that's probably the right answer.
So iron panel with the CBC is usually what you send people to get.
Bare minimum iron panel with CBC. And then I like to get a CMP too, just to get those liver enzymes, because so often, people will have high liver enzymes because of high iron. But yeah, the full iron panel, has ferritin, TIBC, UIBC, iron saturation, serum iron. That's a bare minimum. You don't have to have a transferrin. I think it's nice to have it, but you don't absolutely have to have it. So if you're just looking for the bare minimum, you have to have those, the iron panel and the CBC, and then you might as well get the CMP too. And those are not expensive tests. These are like routine tests that any doctor should and could be able to order. Doctors are good about ordering a CMP and a CBC. They are not great about ordering a full iron panel. They'll often order like an iron or a ferritin, but not like the whole thing. And that's frustrating. It's very frustrating.
Yeah, I can imagine. Do you want to do a quick elevator pitch on the autoimmune connection with all this?
Sure. Yeah. So, high iron does increase the risk for autoimmune diseases. And part of the reason that that's the case is because it creates massive amounts of inflammation throughout the body. And when you have massive amounts of inflammation, then the immune system is going to be going in there trying to heal it up. So there is an increased risk for autoimmune diseases, multiple autoimmune diseases. So the liver is a big one, like autoimmune hepatitis, because people with autoimmune hepatitis, their immune system's going in to try to heal up the liver, but then simultaneously it's like overreacting to the liver because it's just doing so much heavy lifting in that liver area. There's a lot of inflammation, liver-related inflammation. So then the immune system, it sometimes will lose the ability to differentiate between friend and foe, and will, in the attempt to try to heal up the damage, accidentally start going after the body's own tissues. So in the case of autoimmune hepatitis, that's the liver. But other autoimmune diseases that are more likely in people with hemochromatosis, Hashimoto's, so the thyroid, and, iron will get into the thyroid and create issues in Hashimoto's there. Even some inflammatory bowel type issues. It's been shown to increase the risk for leaky gut dysbiosis. So a lot of people with high iron have digestive issues. If you have digestive issues like leaky gut, you're more likely to, in general, just have inflammation and autoimmune type issues. So yeah, there's certainly a connection. Oh, there's also increased risk for like diabetes, like a type 1 diabetes type thing, where the immune system will go in and destroy the insulin producing cells of the pancreas. And so you actually are more likely to have diabetes in that case. But yeah, there's certainly an autoimmune connection, and it largely just comes down to once iron's really high and it gets in those tissues, then the immune system's going to go and try to heal it up. And anytime you have the immune system really working on overtime, it's more likely to make mistakes.
That makes sense. Yeah. Well, Christy, this was awesome. Do you have your own supplement line? I think I just found it.
I do. Yeah.
I didn't know that.
Epigenozyme. Yeah.
That's awesome.
Yeah.
And I see melatonin. I just released a show on that. That's one of those heated topics because they always say it's going to shut down your own production. But you look at like Russell Ryder and Doris Lowe, it's like the research on melatonin is incredible. Even for viruses and stuff.
Yeah. So. Yeah. I mean, if you want a good therapeutic tool, melatonin is amazing. And it actually, I talk about it a lot in the Iron Curse book because it actually does play a role in iron and like increasing hepcidin and lowering iron. But did you know that most of the melatonin in your body is not made by the pineal gland? Most of it is made from subcellular melatonin from exposure to near infrared radiation from like the sunlight. And so that's made in the mitochondria. And so like most of the melatonin, like 95% of the melatonin in the body is made often during the day, subcellularly in the mitochondria. Mitochondria use it like little fire hoses to put out the oxidative stress. Only about 5% of the melatonin is made by the pineal gland at night, circulatory melatonin that goes around. So it doesn't matter how much you supplement with melatonin, you're not going to be able to make up, most likely, for that amount of melatonin you're not making if you don't go out in the sun and get that subcellular melatonin. Having said that, melatonin's amazing. It's an amazing antioxidant for healing up the brain, helping heal up the blood-brain barrier, good for the heart, good for the liver. If you just I think that sometimes people just are looking to say, oh, that's a problem, because then people pay attention, but not really looking at the research.
Right. Yeah. Well, you have some cool stuff. And I think, it's awesome. I'll put the link where people could check that out. And your Iron Curse book, that's not out yet, right?
It'll be out soon, but I have the Laborgenomics workshops, which I have Iron Curse workshop, and then I have, which is a 5-part video series that mirrors the book. And then I have the gut and immune one where I go over like the celiac and leaky gut and all that stuff. And then I have a brain, Alzheimer's, Parkinson's one coming up soon. And then I have the MTHFR and methylation. And I'm going to just do like a series, but those are good also. Awesome.
Well, this is really great info. I appreciate you coming on. And
thanks.
Yeah, drchristysutton.com and Laborgenomics and Epigenozyme. I love it. Well, stick around as we close out the show. Thanks so much, Christy.
Thank you.
Well, that was a really fun conversation. I like that Christy said if someone is not inflamed, then ferritin is a good lab marker. I feel like that should be shouted from the mountaintops, because a lot of people just parrot that ferritin is not a good, accurate lab marker, even though Robert Crichton says otherwise. And it's a very easy, affordable test to get for most people. So I think to say that it's useless is really doing people a disservice. I never heard that hemochromatosis used to be called bronze diabetes. I thought that was fascinating. And now I want to find out how to get my calprotectin tested. I thought that was really interesting when she said that CRP, C-reactive protein, that inflammatory marker, was really low, but calprotectin was sky high when she had Crohn's disease. I think that one lab marker is better than none. And most older people I've spoken with have never had a serum ferritin test. So just starting there, I think, is a real great place to look, because if it's single digit or sky high in the hundreds, then you know that you can start to dive deeper and get more labs done to get to the root of the issue. So if you want to check out Christy's website, you can go to drchristysutton.com. If you or someone you know has hereditary hemochromatosis, it's worth checking out her Iron Curse webinar workshop. My website is matt-blackburn.com. You could read about my CLF protocol on there, click on shop, and see all of my recommended products. Lately, I've really been loving the coffee product from Shen Blossom. It's actually a mix of medicinal mushrooms, roasted and sprouted beans, astragalus, and it's really powerful for someone that wants to take a break from coffee and support their kidneys and adrenals. I've been drinking it every morning with breakfast, and I feel really good from it. It tastes really good, and I really feel it working on my organs. So if you want to try that out and save 10%, you can use the discount code Blackburn on that product or any of the other products on his website. Actually, right now he's having a sale on the coffee product, the old version, and then there's a new one that just came out that is sweetened with my favorite sweetener called Dojo Sweet. All of their teas and all of their products actually are just phenomenal. So I endorse every single Shen Blossom product. They're great. My brand is called Mitolife. You can find that at mitolife.co. We just released a jellyfish collagen product that's called Jellyfish Jolt. There's actually 1 gram, 1,000 milligrams in each capsule. It's difficult to pin down and just say one thing that it does because it affects so many different things: immune health, the gut barrier, nervous system. It even protects cells from excess intracellular calcium because it contains calcium binding proteins. It's the only collagen that has all 20 essential and non-essential amino acids. I like it for the brain boosting effect. And as someone that was vegetarian for most of their life, I really like amino acid therapy, and collagen, especially jellyfish collagen, is a really powerful way to replenish the brain. On YouTube, check out Mitolife Academy. I put up 2 videos a month on different topics, biohacking, latest experiments, and things that I've learned. And then the last day of every month, I do a live Q&A where I answer an unlimited amount of questions. And that's just a way for me to connect with you guys and have more one-on-one interaction. So that's all for today. I'll see you guys next Friday. Stay supercharged.